Okay, so we're gonna do 2 talks back to back, one on how to do TCAR, and then how, finally the last one will be just to compare the outcome of the 3 procedures based on really real data. So this paper, you guys can find it on Journal of Vascular Surgery if you're interested. We wrote one of the earliest paper on how to do TCAR. Essentially, again, it's all about selecting the patient properly. So we get CTA on every single patient. Surgeons, we're used to do carotid endarterectomy based on ultrasound. You can't really do that with TCAR. You really need to get a good CTA. We put all of them on dual antiplatelet therapy and statin. And then essentially, these are the anatomical criteria. You need to have a landing zone, we call it, from the clavicle to the carotid bifurcation has to be at least 5 centimeters. You need the common carotid artery to be healthy because you're going to enter directly through the common carotid artery. You cannot have severe calcification or atheroscleroma because then you're going to cause a stroke. The artery need to be at least 6 millimeter. And you don't want the artery to be too deep. And you don't want a patient that cannot take aspirin or Plavix or both. These are the main things that you need to think about. The kit that comes in for the TCAR from the company has a micropuncture set wire, has this big 8.5 French arterial sheath that you're going to put in the carotid and a 8.5 French venous sheath. You essentially position the patient exactly like you do in carotid endarterectomy, shoulder roll, rotate the neck to the other side. You look at both heads of the sternocleidomastoid, and you go between the 2 heads. So that triangle between the sternal head, the clavicular head of the sternocleidomastoid, and the clavicle. Some people go transverse. I like to go longitudinal incision. 2 centimeter incision is all you need. But I can dissect the carotid artery through a 2 centimeter more proximally and distally, and I can mobilize it, put an umbilical tape on it. And essentially, this is, while I'm doing this, I have someone also getting the venous access, ultrasound guided, micropuncture, then we put the venous sheath and we secure it with a silk. Make sure that you're in the vein. I've seen people put the sheath by mistake in the artery. And then you heparinize the patient. I put a purse-ring stitch right at the common carotid artery ahead of time, pre-stitch, and then I use micropuncture needle and wire to get into the carotid. Be careful, like the rep will tell you to pull a lot on the carotid, but then when you're doing this, you can ovate the carotid, and then the needle will go in the back wall, and then the wire will dissect. And I hear Dr. Abrahma talk about dissection a lot with TCAR. This whole procedure, the biggest pitfall of this procedure is to avoid causing a dissection. Once you get the access safe, the rest is easy. So essentially, once you get your micro wire and needle, you remove the needle, put the micro sheath only 2 centimeter, and then you do an angiogram through that sheath. 2 different views so you can see the carotid bifurcation. And essentially, we have 2 techniques from this moment on. You can stay short technique, meaning that you put your wire in the distal common carotid, not involve the external. So a carotid like this, where there's a lesion right at the bifurcation, you don't want to go into the external carotid artery, right? Because you can cause a stroke. If the external carotid artery is healthy, if the landing zone is too short, I like to get my micro wire and sheath into the external and get myself an additional centimeter or 2. Remember, when you do any intervention in the groin, you have your wire and sheath 50, 60, 100 centimeter inside the patient. Here, your wire is only 2-3 centimeter into the carotid. So very easy, you can lose access, very easy you can dissect if you don't really pay attention to what you're doing. So essentially, after I get my micro sheath and wire into either the distal common carotid or into the external, I remove the micro wire, exchange it with an 035 wire, J wire that is in the kit, and then after that, I dilate the opening of the carotid. So I take the same dilator that came with the venous sheath, and I push it just a half a centimeter into the common carotid artery, not entirely through, just to dilate the opening, get a quick x-ray to make sure the wire is there, and then advance the arterial sheath, as you can see. The arterial sheath has a flow stopper that prevents it from going too far in. And at that time, once I have my micro sheath in, I do 2 different views to make sure that I didn't dissect the carotid, that I'm in the common carotid artery. So these maneuvers that I'm showing you are critical to prevent dissection. Engaging the external carotid artery, dilating the common carotid artery tip, taking an x-ray. Most people just don't want to do an x-ray at this moment, because if you don't do a quick fluoro, the wire is, I can tell you, 9 out of 10 times moved. And then essentially you advancing a 10 French outer diameter sheath into the common carotid artery without a wire. And good luck not to have a dissection then. So once you have the sheath in there, you connect the arterial sheath to the venous sheath with this system right here. Once you do that, you have a passive reversal flow. At this moment, we do something called TCAR timeout. We just take a pause. We make sure that the patient is heparinized, ACT is therapeutic. We put essentially, make sure all our wires and stent and balloon are open on the back table. We give the patient glyco to prevent bradycardia from ballooning. We make sure the blood pressure is high. So this whole technique is based on the delta in the pressure between the arterial and venous sheath, okay? There is no motor there sucking the blood out of the brain. You have an arterial pressure at 160 you want it to be, and you have a venous pressure that is 10, and the blood is gonna go from high to low, and you have reversal flow, okay? So anesthesia tend to treat hypertension. You don't wanna treat hypertension. These patients live at home with blood pressure of 190. Keep them where they are. Otherwise, you have no flow reversal. And then you essentially balloon the lesion. I tend to use a very small balloon, coronary balloon, 3 millimeter, and I put the stent, and I rarely ever balloon the stent. And essentially, I do a quick angio just of the stent. I showed you in the prior talk how I do cerebral angio. That's for transfemoral stenting. With TCAR, we just published a paper in JVS that shows that there's no reason to do cerebral angios. And then essentially, there are, most people do this under general because they're learning it. They don't, they're making a cut down, but I tend to do them under cervical block, and I use the patient communication to monitor their neurological function. You can do this under general with some sort of a neuromonitoring, whatever you usually do with CEA. But sometime when you do it under local, they intolerate. After 7-8 minutes, they might have intolerance to reverse flow. And this is very similar if you do carotid endarterectomy under regional anesthesia, right? So what do? You get the blood pressure up. You essentially sometimes go from high to low flow, and a lot, 9 out of 10 times it works, and you don't have to do anything. So hopefully the video will work. So, but essentially this is showing you how the procedure works. It kind of goes over everything I said. Are you able to kind of, on your end, to push it forward a little bit, advance it a little bit? Because everybody knows that stroke happened here because of embolization. They don't need to see that, and they know how carotid endarterectomy is done. And essentially, the idea with transfemoral stenting, it's okay, Munir, I think it's okay, we're there. So you put the distal embolic protection and you put the stent, but embolization can happen. Now notice how the flow is gonna reverse, and the debris, instead of going up to the brain, is gonna go back through the sheath. And essentially, that's the whole concept of TCAR. And you'll see why this happened, because you have the arterial sheath, and then essentially you have a venous sheath. So here you make the small incision, transverse or longitudinal, and then you put your stitch, there's umbilical tape, and then you put your purse string stitch ahead of time, and then you put your micropuncture wire needle back to the stiff wire, and then you put your arterial sheath, you dilate, here a little bit, and then you put your arterial sheath. And then you have also the venous sheath. Once you connect them together, you'll see here this in a second. I wish we can expedite a little bit, but this is the venous sheath. I like to put it on the contralateral side because it's just more ergonomic the way it sits. You told me, Munir, it's not going to work. I didn't listen to you. But essentially, you have a flow reversal. And this is how this whole concept works. All right, so after that, in the ICU, you put them in the ICU and you watch them just like any carotid intervention. And these are the complications that we already talked about. I tend to put a drain in them and remove it the next day, very small drain so they don't get hematoma. Critical to reverse the heparin with protamine. Okay, I got it. I know I'm done, but I need to go to the conclusion. Can you go to the last slide? So that's it. Proper patient selection, proper medication, proper technique. You can do it very safely with very minimal complication. All right, let's go to the next talk. I'm doing the next one. What I'm gonna do is I'm actually gonna put a timer on my phone here So I know this. Can you go to the next slide? This is, by the way, a picture that I took in San Diego. So hopefully next time we'll have you guys in San Diego, maybe after Dubai, the next meeting. And it looks like this every single day, by the way. All right. Are you going to go to the next talk? So end this talk and then go to the next one. It's this one. So this is essentially just looking at data now. So how do we compare the three procedure? And I'm going to start my timer here. Same disclosure didn't change. I just want to stress that I'm part of the Society of Vascular Surgery Surveillance Project. So the SVS with VQI, they sponsor this project. The FDA wanted every TCAR to be monitored by entering it through our vascular quality initiative. So every TCAR is done in this country, in the United States, is being entered, and we follow these patients and look what happened to them. So the Beki, by the way, I'm sure most of you know, is Lebanese. Most Americans don't know that, but he essentially did the first carotid endarterectomy in 1953. And this is why, let's play that video. Why do we love this procedure so much? Because there's nothing like more gratifying than pulling that plaque with this atheroma that you see, the intraplaque hemorrhage right there. When you essentially know that there are not one, not two, not three, not four, there are like 6 randomized trials showing that you're going to reduce the risk of stroke when you do carotid endarterectomy. And then you essentially get a beautiful artery like this, and then you patch. Most of vascular surgeons patch. And these are the 4 randomized trials that Dr. Abrahman talked to you about, but essentially very beneficial. But we still, today, we don't really know what to do with, stenting. It's still debatable, the role of stenting. And there's also a huge question about asymptomatic patients. Should they be getting only medical management? This is being debated again. So first, CEA versus transfemoral stenting. Every study, like I showed you before, had shown a very high risk of stroke with stenting, with transfemoral stenting compared to endarterectomy. But once you pass the 30 days period, there is no difference in the long-term outcome up to 10 years. This is a very interesting study that did a DWI MRI before and after, and they show these new lesions, these white dots, DWI dots, that there are 5-fold increase with stenting compared to surgery. Now, all these patients are asymptomatic, but the question I ask you, do you want to have that in your brain? If I tell you you're going to have a new lesion in your brain, I promise you nothing's going to happen. Would you say yes? Of course you're going to say no, because we don't know what happened long-term on the cognitive function. Restenosis is similar between endarterectomy and stenting, but stenting really do very well in patients who have a prior carotid endarterectomy. That's one of the best indication, as you see in the study here. As a matter of fact, if the stent narrow again and you have to do something, most time you just treat it medically. It's better to also do endovascular. We've shown this in this largest study ever done on restenosis after stent. And if you do carotid endarterectomy, redo carotid endarterectomy, the outcome is not that great. The mortality rate is almost tripled compared to primary endarterectomy. So I would say, restenosis is probably one area where stenting has benefit. And as a matter of fact, stenting has the safest outcome in restenosis because a lot of time it's intimal hypoplasia and patients don't get the same hemodynamic instability and they have a lot less risk of stroke. So in this analysis, we actually looked at about 50,000 patients and we divided high risk versus low risk. And we found that actually we got it all wrong. The stenting was made for high-risk patients, but actually do well in low-risk patients. So it has the same outcome as the only time transfemoral stenting have similar outcome to carotid endarterectomy is in low-risk patients. Of course, that comes with a cost, right? The cost of the stent and the filter adds up. It's over $6,000 more than doing carotid endarterectomy. This is a nice survey that was sent to about 1,000 vascular specialists across the world. And 50% said they will treat asymptomatic high-grade stenosis with medical management. So there is a huge debate still. Interesting, you see here, like in the US and Europe, the half that they did an intervention, they did a lot more endarterectomy than stenting. If you go to Africa, where we are right now, or you go to South America, stenting, in Asia, stenting is more done than endarterectomy in asymptomatic patient. CRISP trial, we're part of it. We're looking forward to see what's the outcome. But it's essentially, it's 4 group. We're randomizing patient to either stenting versus medical management or endarterectomy versus medical management. When I was at Hopkins, we were the site number 3 in the country in enrollment, and we saw that almost 80% of our patients, their blood pressure got better, their cholesterol level got better with medical management. So the notion that medical management doesn't work is really being challenged. So we have endarterectomy that is beautiful. We've perfected it, has a great outcome, but still there's a cranial nerve injury, there's MI, low, but a lot of the cranial nerve injury actually don't resolve. We say that they do, significant number don't. And we have transfemoral stenting that is made to be minimally invasive, but has twice as much the risk of stroke. And that led to easily to understand that, you know, when we go through the arch to do transfemoral stenting, we shower. When we put the filter, we unprotect it, we shower. This is why we have more stroke with transfemoral stenting. So again, TCAR, avoid the arch altogether, go through the carotid, clamp the carotid, and this is when you have active reversal flow, and you have a CEA-like protection. And this is why the outcome is good, as good as CEA. The procedure time is less than half with TCAR compared to CEA. The clamp time is 1/3 with the flow reversal. And this is the roster 1 and roster 2. These are the IDE study and post-approval study showing the risk of stroke and death and MI to be 3% in roster 1 and 1.5% in roster 2. So pretty good outcome. But again, these are like selected trials, selected patients. So if you look at transcranial Doppler, there's more than 300 hits that happen with transfemoral stenting. But if you see here on the left side, with the TCAR and CEA, the numbers of hits are very similar. And again, I showed you early this, you know, DWI on MRI. They're actually similar with TCAR compared to CEA, about, you know, less than, you know, one out of 5 patients would have them, compared to 4 out of 5 patients with transfemoral stenting. So this was the first study that we did comparing TCAR to transfemoral, and there was actually twice as many stroke and TIA and death in this study. This was about 600 patients that they were propensity score match. And then when we had a lot more patients, we actually end up with over 3,000 patients that we match, again, propensity score matching, and there was half the risk of stroke and death with TCAR compared to transfemoral stenting. And this is the first study that has ever been done comparing TCAR to CEA. At that time, it was only about 400 patients. There was no difference in the risk of stroke or death with TCAR compared to CEA. And then when we had a lot more patients, we had almost 3,800 pairs, propensity score matching, no difference in stroke, no difference in death between TCAR and CEA, but there was significant reduction in the risk of cranial nerve injury and a little bit of reduction in MI. Systematic review that we did also showed the same results, no difference in outcome. And at 1 year, there's 95% stroke-free survival with TCAR. This is the other essentially propensity score matching that we did at 1 year that shows essentially no difference between TCAR and CEA, but transfemoral is worse than CEA. One study here on cost effectiveness. So the cost is a lot more with TCAR, but in this study, cost effectiveness was similar. Dr. Abu Rahma led this guidelines. He kind of did an amazing job with us, 20 of us. I urge you to read them. They're very important. They go over everything. There's 2 documents. One is huge with details, and one is short and brief that goes over all these recommendations, all these studies. And since I'm at 8 minutes, I'm going to skip through those, but I'm going to tell you TCAR now approved in the United States for even low-risk patient, not just high-risk patient. So CEA is the gold standard, remain the gold standard for revascularization procedure in the carotid. Transfemoral has higher risk, but we can do better by proper selection, as I mentioned to you in an earlier talk. TCAR is very promising. It's a hybrid procedure that combines the best of both worlds, transfemoral and CEA. And the outcome so far is much better than transfemoral, but similar to CEA. I personally believe that we need to do a randomized trial comparing TCAR to CEA because we need to have level 1 evidence. All these papers that I showed you that we've done, they're retrospective analysis. We really need to have level 1. We're pushing for that. So thank you so much again.
Thank you.